Topic for this evening, learning on the mission field. Is this a good idea? Is this a bad idea? That's a question we're going to throw out tonight, and we're going to lots of answers. I thought it would be fun to just say, you know, what are some of the things when we talk about international and getting involved? A lot of us have the same questions. Is there something I can do? The things that I bring, and how do you do that?
Should I go? Should I not go? Am I able to make a difference? Tom Brokaw said, it's easier to make a buck. It's a lot tougher to make a difference. One of my favorite quotes, Betty Reese said, if you think you're too small to be effective, you've never been in bed with a mosquito. So with those questions in mind and those quotes, we're going to ask the question tonight, are medical missions a good time for surgeons to learn or relearn techniques? For those of you who just tuned in, my name is Stan Pletcher, and I'm the founder of Global Sight Alliance. And I'm joined tonight by Baxter McLendon. Dr. Baxter McLendon did his ophthalmic residency at the Medical College of Georgia and a corneal fellowship at Oxford Eye Hospital in Oxford, England. Baxter's spent over 15 years living and working as an ophthalmologist in the developing world. He's lived in Tanzania, Malawi, Grenada, Guatemala, and Belize. Besides that, he's worked in Labrador, Ghana, and he's taken many medical trips. He's been to Haiti, Iraq, Peru, Namibia, Jordan, Jerusalem, Israel. He's taught manual small incision in El Salvador, Iraq, and also at the U.S. When he's in the States, he is a visiting clinical professor at Storm Eye Institute, and he currently works in South Carolina in a community health center in one of the poorest counties in the country. Baxter, are you out there?
Yeah. Thanks, Stan, and thanks for everyone who tuned in. And as you were mentioning, tonight we're really going to talk about learning in the mission field. Is it a good idea or a bad idea? And specifically, learning for a surgical procedure, such as a small incision cataract surgery. So we're going to address that. We're going to address it from several different angles, several different aspects, and we're also going to talk about what is the responsibility if you're going overseas to learn a surgical procedure. What is the responsibility for the mentor, for your teacher? Ideally, you would have a teacher helping you with your first several cases, and then we're going to talk about how the mission field is changing, what's going on, and also at the end, if we have time, we're going to talk about how to be an effective volunteer. So that's kind of the overview of what we're going to be doing tonight. I think this is a timely subject, and it's important. So with that, I'm going to ask Nick Patel if he has anything to say.
And let me introduce Nick. Dr. Nick Patel is our second panelist, and he has a broad base of experience also working internationally. He's got some expertise in health systems evaluation and management in the United States and abroad. Nick has worked in Egypt, Kenya, Rwanda, and Ecuador through organizations like the USAID, World Vision, World Relief, the World Bank, and Aid Village Clinics. He's educated and lectured, and he's prepared and presented foundational materials for indicator development and measurement within the Joint Commission and as a consultant to some of its constituent hospitals. Nick has completed his master's in public health training at Johns Hopkins School of Hygiene and Public Health in health systems management and international health. And while in Baltimore, he served as a consultant to the newly opened Johns Hopkins Outpatient Center. So that was all before he became an ophthalmologist. As an ophthalmologist, he's pursued a fellowship in surgical retina at the University of Iowa Hospital and Clinics. And then he joined the Storm Eye Institute as the Bruce Pratt Endowed Chair for International Ophthalmology, where he served as a primary retina faculty and supported manpower assessment and planning in Latin America, as well as subspecialty education in retina in China, Africa, South America, and Central America. Nick has recently just been married and has moved to Greensboro after a whirlwind world tour with his pediatric ophthalmologist wife, Dr. Grace Patel, where they were in Ethiopia, Swaziland, Ecuador, and Paraguay, and a few other places. So Nick is a traveler, as you can see. So Nick, welcome. Thanks for being willing to come tonight.
Thank you, Stan, and thank you, Baxter, for the introduction for our talk today. I agree that we have quite a bit of ground to cover and that this is an important topic and timely. And there's a lot of buzz around learning manual small incision cataract surgery. I think what we'll gain today is an understanding of what some of the factors are involved in a good learning experience and what some of the things that we need to consider when setting up an experience like this. And also, what does the mission field look like with regard to M6 learning? And without going into too much detail, Stan, I'm going to hand it back to you to get us started on the discussion.
All right. Thanks you guys so much. Sorry that our introductions are long for the audience, but here we wanted to tell you a little bit about who's talking. Tonight, as Baxter sort of outlined, we're going to try to break up so you can see our topic. We're going to talk about expectations. What are we trying to do and why are we trying to do it? Let's talk about M6 specifically and learning M6. How do we do that? Let's talk about what the student's perspective ought to be and what the student's perspective often is. Let's talk about the teacher and the process of being a teacher. We're going to talk a little bit about the mission field tonight. And we're going to talk about, lastly, the overview of what does it mean to be an effective volunteer. So starting off really with the question of expectations. And number one, so we have six areas. Number one, we'll start with this. And some of the questions that we're going to entertain in this for Baxter and for Nick are, what techniques are surgeons really needing to learn? And why do we need to learn them in the first place? I thought we were all trained. And so as we think through that, I'll open the floor. And before Nick and Baxter intervene here and share, I'd like you, if you have a question, go ahead and ask that, and we will try to approach those questions that are hitting the topics that we're getting to, so we make sure we get to your question. So Baxter, Nick, let's start with the expectations and what and why we're doing this.
Right. Well, what about goals? What do we hope to accomplish going overseas? Do we want to learn a new technique, and do we not want to learn a new surgical technique as we're talking about? What's why do we want to learn this? I mean, do we really need to learn manual small incision cataract surgery? Is it going to make us a better care for our patients, not only in the developing world, but also here in North America? So those are sort of questions. Also where we're going, the eye clinic in the developing world. What do they expect? What are they hoping to accomplish by our coming as their guest? So it's a lot of issues to address. If we really want to be useful to our guest, to our host. So Nick, what else do you have to say?
Yeah, and with regard to these techniques, I think most surgeons who are trained in the West have a good background of most surgical procedures. The one thing that I don't know that comes clear is manual small incision cataract surgery, and that is an aspect that I think we're going to delve into, but there are specific skill sets that are required, and I think those skill sets are what we need to talk about here, because they're unique to the surgical procedure, and Baxter has done plenty of teaching on this, and I think it's critical that we understand what they are.
Let's ask the next question about some of the differences with the expectations if you are at one stage of your career or another. So let's talk about what might be a difference between a resident wanting to learn something versus someone in the first 5 years, a young ophthalmologist. what's the difference between expectations and perhaps learning for a seasoned ophthalmologist or, let's say, a retired ophthalmologist? Those 4 different stages.
Right. Well, I think it's more difficult for a resident, certainly a resident at this time, to learn this procedure because they really often do not know how to make a scleral tunnel, or they've not had any sort of experience with making a scleral tunnel, and that's a requirement for this operation. Probably the retired ophthalmologist really he needs to be really sure that he has the skills, that he's done his homework, that he's comfortable with this procedure, because there are some new skills required with this operation. It's not as easy as some people would have you believe to make the transition from phaco to a small incision. You've got to get that wound construction correct. You've got to be able to get the nucleus out of the bag, through the pupil into the anterior chamber, deliver the nucleus through the wound, and it can be challenging, even for the phaco surgeon that is quite good and quite knowledgeable. I've worked with physicians that are excellent phaco surgeons, and they can have trouble. I mean, some people will tell you that it's very easy to make this, and it's an easy learning curve, but that is not always the case, and it's very important for anyone coming to the developing world thinking they're going to learn this procedure to really, really do their homework. There's a lot of different ways you can gain knowledge before showing up in the developing world. And perhaps, Nick, you'd like to comment, you'd like to add to that as far as doing your homework for this procedure prior to going overseas.
Yeah, I think it can't be underestimated the amount of homework you can do in preparing to come overseas. I think the procedure itself is multi-step, and similar to any other surgical procedure, similar to sacral multiplication, there is a learning curve, and with M6, the learning curve can sometimes be steep in that you don't have the same kind of visual feedback that you have with sacral surgery that's present with M6. Meaning, when you're doing M6, it's a tactile feel as well, and wound construction, which is unique to M6 surgery. Whereas when you're doing sacral multiplication, much of what you're doing with regard to wound construction is directly visualized. And so there's an aspect of that that's important. The other part, too, is that the mechanics of actually doing the lens expression from the eye are unique to M6 surgery and need to be learned and felt. And so that process of actually doing that takes quite a bit of practice. And so I think when we talk about the expectations and how someone with more experience and training would be able to learn how to do M6 surgery, I think the more experience just prepares you a little more in addressing complications and things you might run into. But I think the most important thing is to know the steps and know what you would run into, what complications occur. And I think we're gonna talk about some of the specifics of the aspects of learning as we go on.
So, Nick, I'm going to ask you the question. Do you think a surgeon should expect that let's say this is a seasoned ophthalmologist, should he expect to be proficient in manual small incision cataract surgery based on one mission trip, let's say 1 or 2 week mission trip?
I think the potential is there, certainly. It really depends, and I'm sure Baxter can speak to this as well, as far as the number of cases that are being done, the case selection, and what kind of mentorship and surgical oversight provided by the surgical teacher or whoever is instructing this seasoned surgeon. The other aspect, too, is that I think you have to have flexible expectations. So if things are going well initially, perhaps you can learn certain aspects of the M6 surgery, but you might hit a point where there's a stall, and it takes a while to master a particular step before you go further. So it is possible. Does it happen for every surgeon? I wouldn't say you can guarantee that, but I think it is possible in 2 weeks to have a surgeon become proficient enough to do M6 surgery, albeit with some supervision.
Mm-hmm. Well, since we've marched into really the second part, we talked about expectations, or are all of a sudden talking about manual small incision cataract surgery. I'm just going to move into the second section, which is really talking about, let's unpack manual small incision cataract surgery. And let's ask, first of all, and maybe this is a repeat, Baxter, what you said, but why is it that surgeons want to learn this procedure, and should we learn this? Should we encourage all surgeons to learn this, or is this just something for those that want to be on the mission field and international field? What is it about manual small incision that we only seem to think about this internationally, and we don't really think about it doing it in the U.S.?
Well, we don't have to really get into all of the advantages, but I think we all understand that there are advantages for this procedure as opposed to a phaco in a developing world. Phacos are high maintenance, they don't travel well, they can break down. Twice in a developing world, I've had a North American surgical team call me that are in country and are totally upset because the phaco that they have brought from the States is not working, and they've got all these pre-ops cataract patients to do, and what do we do now? So for no other reason than it's a great operation to know and be able to perform in a developing world. It can be a quicker operation. It can be not require sutures. I mean, there's a lot of pluses about M6, but you have to do your homework. There's a lot of ways you can get skilled. You can get some skills on how to do this operation before showing up in a developing world. What you don't want to do is go down, operate on a lot of people, practice in the developing world, end up with a lot of complications and a lot of disasters. If you have a surgical complication in a developing world, that patient is not going to be able to see a specialist. There's not a vitreoretina guy that you can send that patient to like Nick. That's not going to happen. If you drop a nucleus, that patient is not going to find a vitreoretina surgeon. If you end up with bullous keratopathy, that patient is probably not going to see a corneal guy and have a endothelial keratoplasty. He's going to have that bullous keratopathy for the rest of the life. You get on the plane, you go back to the States, and you'll never see that patient again, yet that problem will be with that patient forever. There's not going to be any way to sort that out as it often is in the States. Nick, would you like to comment on that? I mean, that it's not correct to go down there and just practice a new procedure in the developing world. I think we all feel like that, but sometimes it gets lost in the shuffle.
Mm-hmm. Yeah, and I agree that you shouldn't go to practice. I think to go to learn is not wrong, provided you understand why you're learning and what your long-term goal is. If you're planning on doing one trip, every few years, perhaps it's not practical. But if you're planning on establishing a long-term relationship, be involved in skills transfer and other things, I think it's important. Getting back to the issue of M6 and why I think it's a really good procedure, the lenses are much harder and much denser. So phaco just doesn't lend itself. And as far as technology goes, the other aspect is M6 is a surgery that can be done with loop, with just a little burner or a candle or cautery. You don't even need electricity, and you can even have a gooseneck lamp if need be with regard to light. So it can be done with very little equipment in the most rural and most primitive of locations. So I think that's important to understand, is that technology demand is very low. and it's suitable to be done in places where you just don't have access to things that we expect in a modern operating room in the United States.
Baxter, I was wondering if you would comment on who do we think are good candidates to learn M6 as surgeons? Is it, as somebody who's your age that learned extra cap and maybe intracap in your residency, is that a good candidate? Is that the best candidate? Or how about a young surgeon who comes out and does, clear cornea cataract surgery? Are they a good candidate for learning? Who is it that we should be encouraging to learn M6?
Well, I think you want to have someone that's really keen to learn it. Probably someone that's a resident or very briefly out of a training might have a hard time initially making the scleral tunnel. Someone that has learned and is comfortable with extra cap, I think it varies a lot, but I think that person might have, at least initially, a leg up on it. I think you have to decide, are you going to teach the local ophthalmologist the procedure? I mean, who's going to learn this new procedure? Is it a North American guest that wants to learn the M6? Are you the expert, and you're going to teach it to the local ophthalmologist in a developing country? If he or she already knows the procedure and you're coming down there to learn, then that person may be your mentor as far as learning this procedure. Certainly, people that are overseas that are doing good surgery, extra cap, you don't need, those people might be better off not learning M6. I've seen that. I mean, if someone's overseas and doing good work with a standard extra cap, there's no need to try to push them into learning M6. That's how I feel about it. And if someone is going to a developing eye clinic and there's already a phaco unit there, then maybe the North American surgeon doesn't need to learn how to do M6. He's already got a phaco at that site and he's comfortable doing it. And maybe that's not the correct. You just don't need to learn how to do it. Nick, what do you think? I think it's important, again, as we keep saying, that you really need, there's a lot of ways you can learn this technique before you end up in the developing world countries. There's videos, there's courses you can take. Ideally, you'd have, your first few cases, you have someone that can function as your mentor, or someone that's done the cases, can walk you through the case, or even take over the case if it's really not going well. What do you think, Nick?
Yeah, I think as far as who should learn M6, motivation has to be there, and you have to have a setting. You can't just want to learn M6 and not know where you're going to apply your skill set. And I think that should be part of the training process. I mean, initially it's getting your basics and your fundamentals of what's involved in M6, the procedure, the steps, the instruments, being familiar with scleral tunnel and how to actually perform the procedure, even in a lab setting. And then ultimately when you go on site and work with the surgeon, it's important that whoever's learning it really understand where it's applicable, case selection, how the patients would benefit from it versus phaco. And again, if the technology is there and the facilities are there and M6 isn't the predominant way of treating cataract surgery, that person doesn't need to learn M6. But by and large, in the developing world, M6 is the staple cataract surgery that's available and performed, and is the way in which cataract-related blindness is being addressed. And so I think if you are going to be an effective participant in that, M6 is a procedure you need to learn how to do. Again, it needs to be based on the setting. You should have a relationship with wherever you're going to, and you should not be the primary caregiver in the area. You should partner with someone. And I think that's something that is critical, particularly as you start out.
All right, I want to ask the parallel question. So let's say I want to learn M6. What might be some parameters that we set for good ways to learn M6 in this setting. If you can set up some idealistic parameters, you say this is the time, this is not the time, or these are the baby steps. Baxter, would you like to address that?
Yeah, I think the parameters should be not to operate if it says if the prognosis is poor. If you have a patient, if you have an eye that obviously has a complicated cataract, trauma, uveitis, old glaucoma, then that's really not a good patient for you to be starting to learn how to do M6 on. If someone has only one eye, I would not try to let that be your first case for M6. Operating on people on eyes that you can get a good pupil, a dilated pupil, is really important, especially early on when you're just starting to learn. You don't want to be operating on someone with a 3 millimeter pupil. I mean, it's difficult enough with a phaco, obviously, but that's not a good patient for you to start learning M6 with. It's good if you have a good mentor there to help you, to really explain to you what's going on. And you have to pick your criteria. Certainly, the criteria for operating on cataracts in a developing world might not be the same as what it is in North America. Mm-hmm. Nick, you want to add to that?
Sure. The parameters for M6 surgery, I think it's critical case selection is the most important thing for any surgery, is to select the right patient for the right procedure. And certainly experience is something that's lacking for a beginning surgeon. And so that's why it's always important to partner with someone who is on the ground and does this and who can really guide you to how to select which patient. And in particular with M6, there are certain ways in which you approach a case, the size of your wound, how you express the lens, where one lens might be softer than another, a large luminescent dark lens is much more difficult to manage. All of these are important to really understand. And as you said, Baxter, you don't want to pick patients who don't have a potential of seeing. And you want to pick patients who can actually have a potential for good outcome. And I think that can't be underestimated. In addition, you want to consider things such as case time. We've all been through training, and certainly if you've taught residents, you know that sometimes cataract surgery for a beginning resident can take not a few minutes, but almost an hour or 45 minutes. And you have to think about that specifically with M6 surgery because you have an open wound and an open eye, more or less, with a large wound. And so you have to be careful about your case time as well. And so these are just aspects to think about when you're looking at, considering M6 surgery for the patients that you're selecting with your mentor.
You know, one thing I think about, in fact, when I remember back to residency, I used to select my staff based on the procedure I was going to learn. I said, I don't really want to learn with this guy because I knew that this may have taken longer, or I knew the teaching. So I just want to throw that out in terms of choosing who you go with or who your mentor is might be important as well. Before we go, I want to ask one more question, and then we're going to do an audience poll here, so stay tuned. We're going to do a poll about learning M6. But my last question to you guys in terms of this is, I just don't get it. Why not learn M6 in your home territory, on home turf, where you got your own equipment, your own medical staff, and people you're comfortable with, your stool, your favorite microscope, and everything else? Why don't we do that more often?
Nick, you want to take that on?
He's smiling.
Sure. Well, what's our standard of care? You really have to think about what is it that we do by and large. If you deviate from that standard of care, are you delivering the best possible care to your patients? And that's not to say that M6 surgery can't give you just as good, if not the same outcome as phacoemulsification. But if the expectation and the standard of care in country is phacoemulsification and you deviate from that, I think it puts you in a difficult situation with regard to legal issues and even with regard to your community, your peers, and your referral source. So that's an important consideration. Not to say that you can't perform M6 surgery, not to say that extracap isn't the right procedure to do for certain cases. It's just not going to be the primary procedure you go to, because most of the cataracts that are performed stateside are not dense brunescent cataracts that would benefit from M6.
All right, well, I'll challenge you on that, Nick. So let's say, okay, take away the 20/50 cataracts. Let's talk about brunescent cataracts in the U.S. We do have them. Everybody has them, and I know they have them in Texas. We have a couple in Michigan. So let's talk about those.
The volume for doing M6 is often not in the States. I mean, if you go to the developing world, you see a lot. At least I do. I see a lot of people that are good candidates for M6. In fact, there's a phaco guy that a colleague that comes to Belize, and he is quick to send me patients that he thinks the nucleus is too hard and he doesn't want to take it on with his phaco, and he says, why don't you do an M6 procedure on this patient? And I think it works out well. I mean, he's just really, really hard nucleus is for some people are difficult to handle with a phaco. I mean, that's not true for everyone, perhaps. Nick, what do you feel? I mean, the volume is better in the developing world for M6.
Yeah, I think you're absolutely right, and the volume is better in the developing world. I think the go-to procedure stateside is probably extracap surgery for a dense lens if phaco is not the preferred choice. But to learn M6 surgery without good teachers, because the other aspect too is you have to find someone who will teach you and how many cases are you going to gather together, and then do you schedule them on a day when someone can come by like yourself, Baxter, and teach a stateside ophthalmologist to perform M6 surgery on their patients? It's possible. It's just not going to happen very often that you have that many cases that get stacked up.
Right. I'm a little bit discouraged about this, guys. I mean, we've been working. In fact, we see some models in the U.S. where there are good teachers teaching M6, and I think it's time that we challenge our residencies. Now, obviously, not every residency can teach M6, but I know there are residencies that do teach M6 and that have qualified staff that know it, and I think that's critical, not only overseas and internationally, but here that we have qualified staff. So I'm going to open to the audience. Does anybody have any comments? If you want to unmute your mic, we will do that. If you like to say something, I'm going to launch. Raise your hand, I guess is what Roger going to tell you. And I'm going to launch our poll here. Here's our question. Where is the best place to learn M6? Now, you can answer all of the above or one or two, so it's not just one answer. So go ahead and click what you think here. And if you'd like to make a comment, raise your hand and we'll unmute your microphone. So do you think the best place is in residency, in your private practice, on your own patients, at a wet lab or at the AAO, at Aravind Hospital or another hospital such like that, or on a mission field with a good teacher, as we're talking about? Go ahead and fill out your poll. We got 43% have voted. We're getting 79%. We're just about done here. Does anybody have any comments on that? Or you can, if you don't want to talk, you can send in a question that you have about this topic. Feel free to do that. And we're at 79%, and it looks like we're finishing up. Okay, so the answers at this point, we had 55% saying that it is they'd like to learn it in residency. 9% volunteered learning in their practice, 36% set for each of the next three answers at a wet lab, at Airvin, or on the mission field. So we've got a pretty split field on that. We're going to move on. Did anybody want to comment on that from the audience? I didn't see anybody raising their hand. All right, good. Very engaging. Anything else, you guys, before we move on to number 3, our student's perspective and the process of being a student and what to do?
Stan, I want to emphasize that I think it's fine to learn M6 overseas, but you really, and stress, you need to do your homework. There's a lot of videos out there on YouTube. I don't know if we're going to get into that in just a minute, but there are a lot of courses at the Academy. CHAP puts on a course twice a year. You showed a couple of courses that are going to be happening. There's a lot of ways you can learn and become familiar with M6 before you actually go overseas to have a go with your first case. Nick, do you agree with that? I mean, I don't think either one of us are saying not to learn M6 overseas. It's just that you've got to prepare and you've got to do your homework and not just show up and start operating without some work on your end.
Yeah, and that preparation pays off when you're actually on your mission trip or working abroad, and that you have a basis and a background, having seen enough videos, having thought through the steps, having imagined yourself doing the different steps, whether you've had a wet lab experience or not. Just that preparation goes a long way in thinking about the procedure and actually performing it. So that cannot be underestimated. I absolutely agree, Baxter.
All right, we do have a question here before we move into the student process. This is a question from a doctor in Texas, and the question is, how many M6 cases would a typical phacosurgeon, and I presume that means an experienced phacosurgeon, need to do in order to become reasonably proficient and autonomous?
Nick, you want to answer that?
Do I have a magic number? No.
I think it varies.
Yeah, you're absolutely right, Baxter. It varies. It varies on the cases that are done. Are they done where that surgeon has really good mentorship, and are they done in such a way that that surgeon, does part of the case for 15 cases or 10 cases, really learns wound construction well, then goes through the other steps and maybe rounds out their experience with 30 or 40 cases, but in the last 10 cases they've been completely independent, doing the full aspect of the surgery, having really learned the steps through the first 30. So there's not a magic number. It really depends. Some surgeons are going to pick it up quicker than others. Some surgeons are going to have a lot more difficulty with certain steps and really need to focus on those, and may have to do quite a few cases just to really learn that aspect. I don't have a magic number. Do you, Baxter?
No, I don't. I would like to say, I know we're not talking about the really technique of M6 tonight, but M6 is more, there's more than one variation. If you look at the videos, the anterior chamber maintainer and on, I mean, there's a lot of ways to do it, how you do your capsular rectus, on and on and on. And so there's a lot of variations on how to do this operation. But one thing that I would stress, that this operation really requires a lot of viscoelastic. This is a viscoelastic dependent operation, and for me it is, and certainly I would stress that for someone just learning the procedure. What do you feel about that, Nick? I know we're not talking so much about the technique tonight.
Yeah, you have to, especially when you're first learning, you have to know what your safety margins are and what you can do to give yourself a buffer when you're working in the eye. And of course, viscoelastic makes all the difference when maintaining your chamber and working around with the lens. Of course, very skilled M6 surgeons can do M6 with very little viscoelastic.
Right.
But I think learning and getting started, absolutely, I think that's an important tool.
All right, guys, let's move on. We're running low on time, so I'm going to move us right into talking about the student's perspective. And let's not focus on M6 as much as just some parameters and variables in how one should learn techniques. We've hit that a little bit in terms of M6, but what should a surgeon what questions should a surgeon ask before they set up a learning experience, or what specific preparation should a surgeon undergo before learning? There may seem like some overlap, but I think there's a little room to thinking about the student saying, this is the kind of setting I'm looking for. I'm not just going to go. So anyhow, if you have anything to comment on the student's perspective.
Well, I think it's nice to have a mentor to go with whatever the surgical procedure is. If you're learning a surgical procedure, it's nice to have someone that has some expertise to be with you the first 5 cases or so. Nick, you got anything else to add?
Yeah, I think it's important to think about the place you're going perhaps is a training facility or is a place where doctors commonly go to learn M6 surgery because they have experience in working through the aspects and the pitfalls that folks approach. That's not the only place you can go to learn, but I think it's an important. If I were to pick a place, that would be one of the things I would consider. And then certainly you want to work with a surgeon who can tolerate your low threshold for needing assistance. Because I think early on with any surgical procedure, you need good support and good backing as you're learning the different steps.
Yeah, I was thinking a little bit about the volume situation. So if you're going into a setting where you've got 200 blind patients waiting and you only have 4 days to do that, that might not be as good of a setting as a trip where you have a great mentor and 30 cases in 4 days.
That's a good point.
So, all right, well, let's move a little bit on to talking about a teacher and what should a teacher think about in terms of processes, procedures, protocols that the teacher's ready to have in place for his teaching and his students, whether that be a national surgeon or a U.S. or another Western surgeon.
Well, I think for one thing, I think it's important that the master surgeon or the teacher or the mentor really make sure that the student understands how important it is to do the homework ahead of time. To ensure that he's spent time with the videos, a wet lab, as Nick pointed out, courses, and not have the student just show up thinking, I can just carry on. And I think the mentor, if you have an observer scope, that's ideal, but that's not usually the case in many operating rooms, developing world operating rooms. I think the mentor needs to be able to really take over the operation. I'll be willing to take over the operation if things aren't going well, and to be at least around to talk to the student through the case if he starts having problems with wound construction or expressing the nucleus. I think having a mentor that really understands procedure and is a good teacher is very important. But as we all know, someone can be an excellent surgeon but not such a great teacher. Nick, what do you think?
Yeah, I completely agree. And being systematic is probably the most important trait a teacher can have, in that they follow a certain step with with their trainees. For example, work with them diligently in understanding the aspects of wound construction, how to make the wound, how to make sure it's wide enough on the inside versus the outside, that it's not too thin. All of these are subtleties, but you can't approach them without a systematic process. And that, how you hold your knife, how you create your initial tunnel, how you widen that tunnel, all of that is critical. And if you bounce from step to step as a teacher, the student really gets lost. If you're systematic and teach your students carefully each aspect of the surgical procedure, then they can put them together and perform the procedure well. It's almost like anything that's done that's very technical and challenging. It's done slowly in steps, and then when it comes together well.
Very good. Now, one comment we had from an audience member, I believe this is from the University of Ottawa in Canada, is that they have the residents do a 2-hour wet lab prior to a 3-week overseas M6 elective, which allows their trainees to hit the ground running, because it's about the incision really for M6. But one other comment I have as a teacher that's something I didn't learn quick enough is one word, and that word is stop. And so I recognize I need to say that sometimes more often, and I guess it's not wrong as a teacher to say that, is it? So, all right, all right. Let's move on now. I think this is a picture from Iraq or somewhere. But Baxter, where's that from?
Yeah, that's from Iraq. The person in the middle holding the shiats is Paul Stankuhler. He's a pediatric ophthalmologist in Houston. He's teaching these ophthalmologists, most of these people around him are ophthalmologists. He's teaching them how to do an EUA, just a basic EUA, and how to do it correctly. So there's a lot of teaching we can all do, and sometimes things that we think aren't necessary or they already know, well, maybe they don't know. So that's what Paul is doing right here. He's just doing an EUA on this child that may or may not have glaucoma. And all these ophthalmologists were very interested in watching Paul do the EUA.
That's good. I'm glad I had you explain that. Let's do a brief venue into the question of the mission field, and how is the mission field changing? We all know that the mission field is a part of the rapidly evolving world, and you go from this kind of a mission setting to this kind of a mission setting where they have equipment, and they may have a femtosecond laser, they may have a phaco machine. It used to be this is the supply of ophthalmologists, and now it may look like this. So let's, and as of course we know, the internet is around. It's much easier to acquire knowledge. Smartphones are everywhere, and telemedicine. So anyhow, any comments about what things that are changing make it harder to learn on the mission field now, and what changes make it easier to learn on the mission field?
Well, the slide right here tells you a lot of things that makes it easier. Ophthalmologists are no longer so isolated as they used to be in the 1980s and 90s. That there's no, with your smartphone, you can talk to someone halfway around the world and send them a picture and say, what do you think? What should I do with this patient that just walked in the door? That's amazing. That is such an incredible advance as far as ophthalmology in the developing world. The Ministry of Health in a lot of these countries are really looking more closely at volunteer physicians. It's not, you really got to show your documentation, and they're looking, they don't want people to just sort of parachute in and start operating on their patients. I think that's a big change. Nick, do you want to comment on some of that?
Yeah, in fact, that's a significant change in many countries. And it's a good change, I think, because you don't want folks just coming in and doing surgery. You want it to be a coordinated effort, and you want it to be partnered with local docs and local care providers. I think the capacity is greater in the mission field, meaning there's more ability to take care of patients. The expectations by patients are higher because of the quality of care, and maybe the number of practitioners has gone up. And also I think the need to impart skills versus being the primary provider has changed. I think there's a greater role in teaching than there is in just being the doc that comes in and, for example, does a lot of M6 surgery to address cataract blindness. I think there's even a greater need to support teaching. And it may involve a combination. It may be that someone comes and they learn M6 and provide some M6 support, but at the same time they provide a lot of teaching to the local docs with skills transfer and knowledge transfer. For example, from a meeting that you might have attended, a great presentation, or to educate, provide an upgrade where it wouldn't be otherwise accessible for the docs that are there in country.
You know, one thing, I think that's good points, Nick. One thing, the ideal is that we will make it so that developing world countries will not need North American ophthalmologists to come, that they will upgrade their infrastructure more and more and more. Their own local ophthalmologists will be doing surgery, and we will be out of a job. That would be, I mean, that's not going to happen in the next 10 years for sure, but it's happened in India. It has happened in India over the last 25 years. They don't need any more volunteer surgeons. They're sending their surgeons to the developing world because they've done it so well, and it's just an incredible success story for India. And I don't think that's going to happen anytime soon, but that would be ideal for Sub-Saharan Africa and Southeast Asia.
Well, Baxter, I think I would say, wouldn't you say that it is happening in South America and in some areas like Colombia? I mean, how many excellent Colombian ophthalmologists are there?
Yeah, it's significant. The manpower development has skyrocketed in recent years, and the number of docs, not just general ophthalmologists, but subspecialists in these parts of the world have increased dramatically, and so the care that's accessible is much higher. Now, is it available to all? No. And that's one of the things that I think there's still great opportunity in the mission field to have care that's affordable and accessible to patients, because even though you might have more docs providing care, it's usually in more urban settings. It's for those who can afford it and those who can pay for it, but still the poor will continue to not receive care because the systems aren't broad enough to support them.
Very good.
Good point.
Let's keep moving. We actually pretty much discussed this, so I'll put this up. We talked about bad situations for learning new surgical technique, and so I don't want to review this again, but I want to maybe hit this one. I'm not sure if we said this in quite as well, but any comments you guys have on this in terms of good situations? Let's see if any of this is new. I guess we've talked about most of this. I like the last point. Baxter, I think that's your point.
Yes. And that's true. I mean, I really feel that way. It's not about us showing up, but what does your host and what does that eye clinic need? What's your best use of your time? You might find that the eye clinic where you're going, they've got local ophthalmologists that are doing excellent cataract surgery. Then you got to decide, well, where do I fit in? What are my skills? What can I offer? Nick?
Yeah, I completely agree, and that's where the expectations of someone who's doing a mission trip needs to really be addressed, and that you have to have expectations that are so flexible that when you arrive, even if you're set up, and even if it's been communicated that you're going to perform M6 surgery or cataract surgery, that when you get there, the situation is otherwise. Perhaps they're not ready for you, or perhaps they already had someone that came 2 weeks before and the surgeries are all done. To be able to move with what the needs are and how dynamic those needs can change, and to meet them, and without having that affect your eagerness or desire to want to get treatment.
Very good. Thank you, guys. Let's finish up tonight with just a few pearls about how we can become effective volunteers, and what would be the characteristics, Baxter, of an effective international volunteer.
Well, I try to be flexible. I try not to see what their needs are and to try to go with the flow on that. And really understand that the teaching, who you want to teach, who you want to train, is a person standing next to you. It doesn't have to be the resident. It doesn't have to be a local ophthalmologist. One of those slides we showed earlier, I got 4 nursing students surrounding me, and I gave them a couple of lectures on ophthalmology, and I made sure that one of the local ophthalmologists gave them some talks. That's the next generation. Teach them how to flip a lid. Teach them how to check a visual acuity. I mean, really, you can just, I mean, there is teaching you can do all over the eye clinic, not just in the OR. And if you do it diplomatically, you're leaving behind some useful information for the next 30 years, perhaps. Oh, so Nick, what do you think?
I think that's what you hit the nail on the head there. Is teaching, transfer of skills. The other thing is build relationships, build long-term relationships with a particular clinic or particular location, and be a part of the lives of the docs there. Don't go once, go twice a year if you can. Go every year, but be a part of the care and the work that's being done there.
Very nice. You guys are hitting the nail on the head. I agree with Nick. Those are incredible pearls, and I certainly forget to teach outside of the OR as much as teaching in the OR. And I think that's our surgeon mentality that does that to us. But does any audience member have any questions as we wrap up here? We want to thank you all for staying. We are about 10 minutes over, and we appreciate your attention to this matter. We have been challenged with this and wanted to kind of explore it through Global Sight. We have a few articles that are out there, and we've done some polling around the world of ophthalmologists. There's an article on Global Sight that has just been published about this specific subject, and so if you're interested in that, I would encourage you to do that and share comments about that, certainly. And please share this webinar with anyone who you think would be appropriate. It'll be in our archives, and we'll be glad to have people interact with this. I'd like to share a word of wisdom I think that Gandhi said that was awesome. It's the quality of our work which will please God and not the quantity. So as we wrap up, we have Roger's going to say a few comments, but I want to really extend my thanks to Dr. Nick Patel, who's now in North Carolina, and Dr. Baxter McLendon, I believe, is in South Carolina right now, as some awesome volunteers around the world, internationally, and giving their advice and expertise. We thank everyone for coming. I'm going to turn over to Roger here to finish up.
Thank you so much for coming this evening. Just a couple of thoughts as we are departing. Just to remind you that we do have a website out there, globalsight.org. See if I can get it up on the screen there for you. That you can go to and see all the resources there. And there's a web address. We also are part of another organization called Vision Outreach International, and we also have our M6 training and information there. And then if you'd like to receive some extra information from time to time, you can just like us on Facebook, and we try to update those from time to time and give you the information that's going on. Thanks so much for joining us tonight. This video, as we said, will be on globalsight.org, hopefully in the next 2 weeks, and you are welcome to share it with anyone that you'd like to. Thank you again to Dr. McLendon, Dr. Patel, Dr. Pletcher for sharing with us tonight, and we trust that you have a wonderful evening. God bless.